Dear colleagues, thank you so much for having invited me in contributing with a lecture to the Anesthesia Congress of Russia, also this year. Unfortunately, I cannot participate in person, and I really hope that in a real and close future, these shortcomings will be overcome. What we are going to review it today together is excellence in neurocritical care. And I choose, again, the image of Tintoretto taking care of the heels of the plug. So is there a role of neuroscience intensive care unit in managing our patients? Does having dedicated units lead to any improvement? This study published 20 years ago suggests that the specialized team deliver a better care with reduced mortality and shorter length of stay. In this worldwide survey, in more than 140 hospitals, the respondents reported how most common diagnoses for neurocritical care admission are intracranial hemorrhage, risk-adjusted mortality in patients with traumatic brain injury has substantial advantage when treated in specialized critical care units rather than in general ICU, and patients treated with neurocritical care after acute brain damage have lower mortality. So I do have no conflict of interest, and we will review some hints in specific subgroup of patients when we are intended to treat traumatic brain injury, subarachnoid hemorrhage, acute ischemic stroke, or postoperative care after brain surgery. We will also shortly discuss some evidence on communication and research. This is a beautiful painting in Venice. You see the colors. This is why Tintoretto took his name, because of the traditional family of bringing the colors into tissues. Critical care management of patients with traumatic brain injury include different possible causes, falls, road accident, assault, and mortality in different subset of patients is different. And after falls is up to 32%. This is often a more advanced age, while road accident is 22%. But we should be aware that beside and on top of that, there is also, after severe brain trauma, a substantial proportion of more than 60% presenting severe disability or death. So we are heading to the two combined unfavorable outcome categories. And this is what we have to work on. And long-term neurological outcomes after TBI changes if patients are admitted to a general ICU or to the general ward. And there is an evidence of beneficial effects of dedicated intensive care treatment. On the other hand, it is sad to remember how the last version of traumatic brain injury guidelines report only 28 evidence-based recommendations, and out of these, only one is level 1A and is not to use steroids. All the others are either level 2 or level B or level 3. And as application is the only clear level 1 evidence. So what can we do to improve the care of these patients? It is clear and decompressive are nowadays considered third-tier therapies and should be reserved only to those patients that have refractory ICP elevation. It is also clear that routine use of intracranial pressure monitoring is not associated to a net benefit. Do we know what we can do to the link of nutritional strategies in these patients associate with higher mortality? And I want to underline how to delay beyond the 7th day the starting of nutrition is associated with a 4-fold death rate. Subarachnoid hemorrhage. Is there something we can do? Is a retrospective historical observation, 2 periods before the vascular team and after, 2004 to 2007, 2009 to 2000. Study is that after the implementation of a dedicated neurovascular team, despite the severity of treated patients, is higher quality and a quality of recovery and competent colleagues taking care of these patients. We all know about the changes over time in the optimal treatment of patients presenting with subarachnoid hemorrhage. In 1994, the expert consensus proposed a triple H therapy as a standard. After a decade, it became clear that at least 2 of the 3 H associated with a worsening in increased mortality, overload our patients with an excessive fluid therapy, and the induced hypertension approach should be limited to patients presenting with delayed cerebral ischemia. This is a survey that we launched a few years ago within the neuroanesthesia subcommittee of the European Society, and it clearly represents how huge is the variability of treatment and protocols throughout Europe. And this is partially because evidence with ultimate strength are limited, and partially because the individual approach based on I think and I believe without going through the available and current evidence in the literature is the most diffused approach. We should change our mind. We should make clinical evidence the driver of our therapeutic choices. Aspect is to define a institutional, possibly evidence-based treatment protocol for these patients. As you can see, the presence of such a protocol is extensively different in the various countries, ranging from 18% to 56%, 52%. So there is the need to establish institutional protocol that should be systematically revised and updated. This is a study we published a few years ago in cooperation with Paolo Gritti, a colleague from North Italy, and Seuna Kejou, the current chair of anesthesia at the Massachusetts General Hospital and Harvard University. It is striking how in 22 years, 11 guidelines and 11 surveys on clinical practice were published. This is the indicator of how inconsistent are the available evidence. What we do know, despite that outcome and increased rate of delayed cerebral ischemia. In this study, a cut point of 173 millimeters of mercury during ICU stay was used as a threshold value. I think we should all cope with this evidence and aggressively prevent hyperoxia in the patients presenting with subarachnoid hemorrhage. Similarly, hypocapnia that is necessarily iatrogenically induced associate with higher incidence of vasospasm and increased in-hospital mortality. This should be aggressively avoided. For the positive fluid balance is another iatrogenic induced complication that determine a worsening of the and inadequate or suboptimal glucose management with extensive changes in cerebrospinal fluid glucose concentration is a predictor of poor outcome. What about the neurocritical care management of patients with acute ischemic stroke? Is there an indication to neurocritical care admission? It depends on the clinical presentation of these patients. So a quantitative scoring of the clinical status should be systematically run, and triage to neurocritical care should be decided not on subjective criteria, but on established and consistent institutional protocols. Outcome predictors, of course, the quality of outcome and those patients presenting with an advanced onset in comatose state have a worse outcome, and the necessity for mechanical ventilation are indicators of ICU treatment criteria. Also in these patients, it's clear that hyperoxia is associated with a worse outcome. In this study, a cut point of 3 groups presenting with more than 300 millimeters of mercury of PaO2 had a worse outcome and increased mortality, even when compared to hypoxic patients. So very important in patients with acute ischemic stroke and intracranial hemorrhage to avoid excessive oxygen delivery. This is a study from 6-7 years ago. The erythropoietin used in the outcome, and so again, using a dedicated institutional protocol, there might be indication for early treatment of anemia. Post-operative care in the neurocritical care unit. We all know that after brain procedures, when possible, patients should be extubated in the early phase the longer we keep the patient intubated, the higher is the cardiovascular workload. We also know that specifically the main predictor for successful extubation in these patients is the it's not like respiratory patients. It plays a role in neuro patients, the neuro profile, the cognitive status, the neurological conditions is the predictor of successful extubation. Of course, we can and we should, and we should be aware how in these patients, deep vein thrombosis and pulmonary embolism might represent the substantial risk factors. Of note, in this study, more than 4,000 patients, 86% of the 3% of patients that developed DVPPE were receiving low molecular weight heparin. So pharmacological prevention is necessary when feasible, but is not the only measure, and mechanical prevention should be extensively used. Is it always indicated to admit a patient? And this is the point. It depends on the quality of care delivered in the ward, depends on the severity of the postoperative condition, depends on the general conditions of the patient. So this is an editorial wrote a few years ago for current opinion critical care. Here there are some conditions that might suggest the need for neurocritical care treatment, epilepsy, arterial hypertension, and so on. But it's important to establish a local protocol and to be open to discuss and reevaluate the problem. Communication and research. Communication and research are both critical steps in the delivered quality of care, and we should be aware how important on this. The neuro patient and the relationship with their relatives is a unique setting. We know that we are dealing with a patient that often was normal, 100% normal until the day before. And so we should be compassionate and present in accompanying the relatives into the change of conditions that they are experiencing. Precision medicine is probably the future. Expand dedicated and translational biology research. We know that in neuro patients, not all the recorded evidence in the preclinical setting extended to the clinical setting in a manner. Accept the small success. Of course, this is the underneath thought of treating patients with acute brain injury. Design and test targeted intervention, even at local level. Institutional protocols to be regularly reviewed. Make it user-friendly for bedside clinicians. Complex algorithms are not useful, but we should keep in mind where are we heading for. And last but not least, work together. Precision medicine includes quality of communication. So in conclusion, yes, there are evidence that currently prove how the neurocritical care management of patients with acute brain injury does provide a benefit. And there are specific hints that characterize the treatment of these patients, adequate and optimal hemodynamic and ventilation management, I would say appropriate nursing, the importance of nutrition and communication and research, update within the treatment group. The designation, what you read outside of the door, is not relevant. It's not if you write outside ICU or NICU or neurocritical care, but it's what you do. So the quality of care doesn't not what you actually outside of the door, but on what you do and the clinical decision making in the individual patient. Excellent depends on multiple factors: training, dedicated, communication, teamwork, advanced skill. So the quality depends on how the care is delivered. Quality criteria: not too much of oxygen, not too little of hypocapnia, amine titration when needed, keep electrolyte stable. Thank you for your attention, and keep in touch for future personal meetings. Thank you.
Thank you, Federico, for your lecture. Профессор на связи с нами, да, насколько я понимаю, до конца этой лекции? Thank you. Друзья, есть ли вопросы по поводу этой лекции, потому что у нас хороший запас времени, около 10 минут. Мы идем с некоторым опережением графика. Может быть, у Ивана Анатольевича, как представителя нейроинтенсивистов, из тех, кого я вижу здесь, есть какие-то вопросы, желание что-то обсудить. Друзья, для тех, кто внимательно смотрел, хочу подчеркнуть, вот кто обратил внимание, бросился в глаза термин краниоэктомия. Иван Анатольевич меня поправит, если я не прав. Это не ошибка. Такой термин действительно существует. Да, Иван Анатольевич, может быть, несколько слов все-таки, поскольку мы с Артемом Николаевичем не представляем когорту нейроинтенсивистов, как вы и Федерико. Может быть, несколько слов от вас.
Very nice to meet you, Federico. If you see me. Okay.
You may look at the camera.
Federico, hi. Very nice to meet you. Okay, one question about hyperoxia in two groups of patients.
Первый вопрос о гипероксии в двух группах пациентов.
One with subarachnoid hemorrhage.
Одна группа субарахноидальное кровоизлияние.
Did the research use T-brain02 in this subpopulation of neurocritical patients? And the second group with insult, with hyperoxia. What's the idea?
Stroke,
yes.
yeah.
What's the idea to use hyperoxia in this group?
Что по поводу гипероксии в этой группе?
Ciao, Ivan. How are you doing? I remember you. This is not my study. This is a study that I searched and I included in my lecture because I think it's an extremely relevant point. There is another recent paper from a Japanese group that moved even further. They, in the latter study, they demonstrated that every single episode of hyperoxia in patients with subarachnoid hemorrhage in any phase of the treatment, so even during transportation, every single episode of hyperoxia associated with an increased risk of what is called delayed cerebral ischemia or increased vasospasm and worsening outcome. So we know.
Я бы хотел подчеркнуть, что в своем докладе это не было предметом моих исследований. Я включил ряд ссылок на исследования других коллег. И в отношении вопроса о роли гипероксии при субарахноидальном кровоизлиянии есть результаты недавнего исследования японской группы ученых, которые доказали, что каждый эпизод гипероксии в любой момент, на любом этапе лечения пациентов с субарахноидальным кровоизлиянием даже, например, на этапе транспортировки ухудшает исходы, влияет на развитие вазоспазма и ухудшает исходы лечения этих пациентов. Отложенные ишемии.
Long-term outcome.
Влияет на отдаленные исходы в том числе. Yes.
Okay.
Thank you. So we know that hyperoxia is one of the mechanisms that mostly impact cerebral blood flow, but this is especially true in patients with subarachnoid hemorrhage. And the message I want to share with you is that oxygen, we already know it, but we have to remind, this is the reason for meeting again. Oxygen is not always good. Oxygen is good to a certain extent.
Мы знаем, что парциальное напряжение кислорода и гипероксия в значительной степени влияет на мозговой кровоток, и это особенно выражено у пациентов с субарахноидальным кровоизлиянием. И основной посыл, который я хотел бы озвучить в своем докладе по результатам этих исследований, это то, что кислород — это не всегда хорошо. Это хорошо только до определенного уровня.
Okay, thanks a lot, Federico. And one more question. What is your personal approach for transport your neuro-unstable patient, etc., MRI and maybe CT scan? What the type of monitoring do you use during transportation? I think it's a very practical approach for our guys, and I think your opinion will be very interesting for us.
Вопрос к профессору о его личном подходе, мнении о том, как организовывать транспортировку и мониторинг во время транспортировки нейрореанимационных пациентов, нестабильных нейрореанимационных пациентов, например, для проведения КТ или МРТ-исследований.
I like the question because it allows me to be very practical.
Поскольку я в ответе на этот вопрос могу отвечать абсолютно с практической точки зрения.
When I transport a patient, I see how the patient is before I move it. So the respiratory rate, the fraction of oxygen, the sedation level, and I keep it constant.
Естественно, до транспортировки я оцениваю состояние пациента, его частоту дыхания, сатурацию и другие показатели, и стараюсь поддерживать их постоянными, стабильными.
So if the patient is on 12 respiratory rate, I try to keep at 12. If the patient has 35% of oxygen fraction, I keep it at 35. If the respiratory rate is 12, I keep it at 12. And I only use the pulse oximetry. So I try to keep the transportation as easy as possible. Transportation is critical, but we do not have to make it even worse.
Я стараюсь поддерживать, как было уже сказано выше, все показатели стабильными. Транспортировка для этих пациентов – это очень сложный критический этап, и нужно обеспечить стабильность, но и подходить к этому максимально просто. То есть если у пациента исходная частота дыхания была, например, 12, я стараюсь поддерживать ее в этом диапазоне. Фракция кислорода вдыхаемого 35 также поддерживаем в этом диапазоне и обязательно использую пульсоксиметрию.
I hope this was clear enough.
Thanks a lot. Я от себя хочу добавить, что на самом деле это очень важный момент, и таких пациентов надо, естественно, вентилировать транспортными аппаратами ИВЛ. Вы это прекрасно понимаете, потому что, например, вентиляция в режиме аппарата АМБО, она просто очевидно не создаст константные параметры хотя бы по end-tidal CO2. И вот интересный момент, мы еще проводили как бы транспортировку таких пациентов с использованием мониторинга внутричерепного давления в момент транспортировки, и есть несколько критических точек транспортировки. Но прежде всего, как понятно, это перекладывание пациента. Всегда пациент на любое перекладывание реагирует повышению внутричерепного давления. Поэтому, если возможно выполнение исследования на той транспортной каталке, которая, предположим, часть СКТ аппаратов оно позволяет задвигать, то это тоже допустимая вещь. На самом деле, действительно, транспортировка – это тонкий момент, за которую можно много потерять в лечении пациентов, хотя она бывает неизбежна.
And the addition from Professor Savin is that it is highly advised to use transport mechanical ventilation machines, not the MBU bag, and also to monitor intracranial pressure if possible, because we have an experience of monitoring intracranial pressure during the transportation, and we see, especially when we move patients, it's an increase of intracranial pressure. So if possible, to use the same
Device.
Setting.
the same trolleys for the transportation and for the investigation to decrease the rate of moving patient. So the whole idea of transportation of these patients is a very critical issue and very complicated.
I fully agree.
And Federico and Ivan Anatolyevich, in my view, the most terrible place is elevator. Elevator, which is
By the way, one of critical place. Yes, of course.
very tight and very terrible place for any transportation. Intra-hospital, I mean.
I fully agree.
Thanks a lot.
Thank you, Иван Анатольевич. Не уходите далеко, если можно, потому что, dear Federico, thank you, and I'd like to present the next lecturer, who is also neurointensivist. You know, Dr. Alexander Zlotnik from Israel. You do know him perfectly.